Patients who are planning a breast augmentation will often ask me, what is our plan for incision placement for our breast augmentation? So I'd like to talk a little bit about that. When you're planning a breast augmentation, we have a few options for the placement of the incision. In the past, my favorite incision placement for breast augmentation was the periareolar, which is the incision just around the bottom of the areola. Now, the areola is the colored portion of the nipple, right? The bigger circle around the nipple that's darker color. And right at the margin of the colored and non-colored skin, you can place an incision, go in through the gland, and place an implant behind the gland, either under the muscle or right behind the gland. But when you go through the breast gland next to the nipple, you have a higher chance of contamination of that implant with nipple bacteria, whether it's the bacteria that live in the nipple or whether it's the bacteria that are inside of the glands and inside of the ducts, because the breasts are colonized with bacteria, just like your ears, just like your nose, just like every crevice in your body. Every part of your body has native bacteria, and skin bacteria live inside of the nipple ducts and inside of some of the glandular portions of your breast. So when you cut through the areola and you travel through the breast gland, there is a risk of contamination of that breast implant with skin bacteria. Now, of course, at the time of breast augmentation, we wash the pocket with antibiotic irrigation, with betadine, we re-prep the skin, we prep our gloves, we change gloves, and we treat all of those things carefully using evidence-based techniques to minimize the risk of contamination of that implant with skin bacteria. However, well-designed prospective studies looking at capsular contracture risk with periareolar or nipple incisions versus the inframammary incision versus other types of incisions have shown that the lowest risk location for an incision in the risk of capsular contracture development is the inframammary incision. The inframammary incision is a short incision, in most cases shorter than 4 centimeters, right along the fold where the underwire sits underneath the breast. So in the breast shape, you have an area under the fold of the breast in which we can place a short incision, less than 2 inches, that is under the breast, and we can travel straight underneath, not disrupting the glands, a low chance of disrupting the nerves to the breast, a lower chance of sensation changes to the breast and the nipple, and a lower chance of capsular contracture when you place the implant through a short incision at the inframammary fold. The inframammary fold is where your underwire sits anyway. Most of us have a crease in the skin because we wear an underwire bra, and this is a very nice location in which to hide the incision for a breast augmentation, because underneath the breast it's really not visible. So I prefer a 4 centimeter incision along the fold of the breast at the planned new inframammary fold for breast augmentation. Other options for breast augmentation incisions include the umbilicus. Now remember, the umbilicus is not a clean space. There's skin bacteria in most patients. There's folds. So when you place an incision in the umbilicus, or a tuba, transumbilical augmentation, you have a higher risk of contamination of the implant, a higher risk of capsular contracture, and a much higher risk of asymmetry because the implant's been placed through a tunnel all the way up your abdomen and all the way into the breast. Even if you have a 1 centimeter difference in the left and right breasts, it's distinctly noticeable in the final result. So I do not like the transumbilical augmentation because the implant's placed through a long tunnel, nearly blindly or with an endoscope, through a not clean orifice of the body, creating a higher risk of capsular contracture. And because it's a long tunnel, you have a risk of disruption of the inframammary fold, which is ugly when you have your shirt off, or an asymmetry of the breast because you couldn't directly see the pocket that you've created. Finally, there's the axillary or transaxillary or armpit incision for breast augmentation. I don't like the transaxillary augmentation because this is Texas, and we wear tank tops like 9 months out of the year. So who wants a scar in their armpit? Let me tell you, patients who've had lymph node surgery through their armpit have a scar in their armpit forever. And every time they wear a tank top or a bathing suit or lingerie, that armpit scar is visible. And when you raise your arm for any reason, answering a question, amusement park ride, or just hanging out, hey, how are you? There's a scar, and everybody can see it because armpit scars are very visible. And the clothes we wear in Texas, 9 months out of the year, are tank tops because it's hot here. So who wants to have a visible armpit scar or two? Nobody. And so those are those are reasons that I don't like armpit scars for breast augmentation. I think the best place to hide a scar for an augmentation is in a short 4-centimeter scar under the breast. We can use a device called a Keller funnel, slid in through a very small incision along your fold to deposit that breast implant into a very perfectly made pocket inside of each breast, reducing or minimizing your chance of difference in the left and right side, minimizing the contact of that implant with bacteria in your umbilicus or your armpit, and finally getting the best symmetry we can get with the lowest chance of loss of sensation to the nipple when we use an incision in your infirmary fold.